So, good afternoon, everyone. My name is Mark Driscoll. I'm a program manager at the Ohio AAP. I oversee the preventive health program, and we are happy today to have our speaker, Mary Renaud, join us to continue our motivational interviewing series. This is the second session in the series of four. And the first session is recorded and up on the Preventive Health webpage. So if you're interested, I will send a link to that with a follow-up email today, as well as information about applying for your CME credit or MOC Part 2 credit. Otherwise, I don't have very much else to say for now, except that I will introduce our speaker and then let her take it away. So Mary is a licensed professional clinical counselor with supervision designation. She has experience working with children, adolescents, and adults in treatment settings such as community crisis, juvenile and adult corrections, inpatient psychiatric units, in-home therapy, residential care, and outpatient levels of care. Currently, Mary is a staff developmental clinical supervisor at Dayton Children's Hospital, where she provides clinical supervision to counseling trainees and licensed professional counselors, in addition to supporting training and clinical development for the counselors and social workers within the hospital. So without further ado, Mary, the floor is yours.
Great. Well, thanks, Mark, for that introduction. Um, and welcome, everybody. I appreciate everyone who is on the call, and I hope everyone has been able to stay warm with all of our crazy weather that we've been getting over the last couple of days. Um, but I am very excited that we get to continue talking about motivational interviewing. Let me make sure I can move on. Nope. There we go. Um, we have no financial disclosures to report or share relevant to today's presentation. And so, like Mark was saying, this is part two of our four-part series um, in motivational interviewing. So we got to hear from Dr. Bowling last week, who covered practical strategies for MI. We covered open-ended questions and um, or ors and open-ended questions. There we go. And Dr. Bowling and Dr. Chavez are both on the call here, so feel free to jump in at any point and share any thoughts that you guys have as well. And so today we are transitioning into talking about two tools for success, assessing values and readiness. And then next week we'll get to hear from Dr. Chavez to cover reflections, and then we'll get a chance to put it all together at the end. Oh, real quick, before we kind of jump into review, I do want to just remind everybody that you guys, we would like this to be conversational, in and discussion based. So if you have any questions, you don't have to wait till the end. You're welcome to put them into the chat. I will try to keep an eye on the chat, but I will also rely on Mark to make sure I don't miss anything that comes through. Or if you have a question or a comment, you're welcome just to unmute and throw that out too. That will not bother me at all. So without further ado, we can jump into just a quick review. So I wanted to cover a few things that were highlighted last week, and then share just a little bit about some things that might be relevant to today's conversation. So like we talked about last week, the goal of motivational interviewing is to help an individual resolve ambivalence. Ambivalence is that feeling that we get when we're stuck in the middle of two choices, and we can usually produce a pretty strong rationale for why each is a good choice. Like Dr. Bowling talked about last week, right? This is super normal and common for us as humans, right? It can be, the experience of not of what do I want to order at this restaurant, right? We can have ambivalence around that, all the way up to like some pretty significant life choices of do I want to explore this job opportunity? Do I want to, what college do I want to go to? Do I want to start another degree program, right? Those are all things that produce ambivalence, and that feeling is very normal. And so it's going to be normal for our patients as well. Um, One of the concepts I wanted to kind of add in, though, that I think will apply to our conversation today about values, is cognitive dissonance. So, cognitive dissonance is a psychological concept that describes that feeling that we get when our actions and our values don't match. So, for most people, when our actions are outside of our values, this produces some level of discomfort for us, all the way up to like pretty significant feelings of shame and guilt. Um, and so, in order to resolve that feeling of discomfort, for most people, we engage in some level of defense mechanism in order to reduce that discomfort. So, common defense mechanisms that will come up to help us in these moments is minimization and rationalization. So, just a couple of examples. Let's say we have someone who is a smoker, and for most people nowadays are aware of the many health ramifications that come from smoking. And so, for a lot of people, right, smoking is going to be outside of at least one of their values, maybe health, family, that sort of thing. And so, we may engage in like some level of minimization, of minimizing the potential risks that come from smoking as a way to reduce that discomfort between our behavior and our value. We can also use rationalization to kind of rationalize our behavior. So let's say, for example, you maybe lied to someone that you care about, maybe a friend or a family member. And the way that we can kind of rationalize that is telling ourselves that a white lie isn't going to hurt anybody, right? So we're rationalizing that behavior in an effort to reduce that discomfort. Um, as a defense mechanism for most of us is strong and in place, right? We don't see a lot of ambivalence because that defense mechanism is preventing us from feeling any discomfort. But as that defense mechanism is broken down, whether that's through new information we're receiving, whether that's through being confronted by a friend or a family member, or even in a conversation with a provider, right then that makes room for that ambivalence to kind of sneak in as a defense mechanism comes down. So that's kind of how, right, our cognitive dissonance and ambivalence are going to be related. Um, Anything that you guys would add, Dr. Bowling or Dr. Chavez?
Sounds good.
Okay. Um, oop, here we go. So one more thing that I wanted to review from last week was just the four processes of MI. So these are changed to the four tasks of MI, and we have engaging. So this is that relational foundation. This is kind of one of the most important tasks that we have of MI. A lot of the research shows that we usually can't get anywhere if we don't have this. So we want to make sure that we are dedicating time to that engaging step and making sure that we have that strong relational foundation. The second task is going to be guiding. So this is where we are going to work with the patient to create a focus for our session or focus for the time that we have, or maybe a specific behavior that we want to focus on. Evoking is when we get to, often that's when we are using a lot of our MI strategies at that point. We're pulling things out from the patient, evoking different things related to change talk, so that way we can, right, help them move through those stages of change. And then our last task is planning. So helping to bridge that gap between like contemplation and action, right? Moving into that change. Throughout each of the tasks, no matter where we are, we're always going to be looking for that change talk and trying to reflect that back to our patients. So, what we're going to cover today, just a quick review of some objectives. We're going to identify strategies for assessing and evoking values, explain the principles of scaling questions to assess readiness for change, and then apply those in clinical settings. So just a quick summary of our two tools. We have assessing values. This is helping our patients identify the values that are important to them, and then assess how that relates to those behaviors. So really working through and exploring that cognitive dissonance. And then assessing readiness. So this is helping our patients identify how ready they are to make the change and how confident they are in their ability to make the desired change. So we'll talk about the tools that we have available to do both of these. But before we dive in to assessing values, I wanted to take a second just to talk a little bit about and maybe define what values are to begin with. So if you want to throw it in the chat, or you're welcome to unmute and report out. But if you had to define values, what would be your definition?
What people think is important.
Yeah, what people think is important.
We have our guiding principles, the things we believe in,
Okay. I like the word guide. Guiding principles, yes.
strongly held beliefs, if
Mm-hmm.
important, or closely held virtues,
Mm-hmm.
conscious guidelines.
Mm-hmm. Yeah, I think those hit on kind of all of those constructs of value, right? So things that are important to us, the things that are going to guide us, help us to make those decisions. How I like to explain values to kids and adolescents is very similar to the language that you guys all developed or shared here. Is what is most important to you, and that we can use that as a guide to help us decide and make some tough choices, right? MI is about resolving ambivalence where we're stuck between two choices, and we can utilize our values to help us make decisions when we feel stuck in that place. So, for most of our patients, they don't have the language necessarily to come into our visit and say, you know what, I have noticed, I've been reflecting, I have just, noticed that my behavior is outside of my values and I want to work on changing that. For our kids, adolescents, and family members, right, that's very uncommon for people to do that. And like come to bring that to us. And so one of our tasks as MI providers is going to be evoking that conversation of values and pulling that into the conversation. So there's a couple of different strategies that we can use to evoke values from our patients and to bring that into our discussion. So we can use reflections. This is where we're going to be listening as our patients are talking to us, listening for values and then reflecting that back to them. So, for example, we may say something along the lines of, it sounds like family is something that is really important to you. Or what I'm hearing you say is that you really value honesty. So, really kind of making sure that that is a lens that we're kind of listening through um, and being able to reflect that back to our patients. Um, Another tool that we have to evoke values is going to be to use open-ended questions to pull and create space in our conversation for value discussion. So we may say something along the lines of, when you think about giving up smoking, what are some of the most important reasons you're even considering making this change? So really creating that space and doing some guiding, right? Guiding the conversation to talk about values and pulling that in. And I know not everybody who's in the audience is going to have the time and space for this in their work with their patients, but we do have access to some values assessments and tools we can use in this process. So for those of you guys who are in any kind of like therapeutic role with patients and have the time and space for this, these are great tools to use to help patients assess and create and establish kind of what values are most important to them. So we have assessment tools. So these typically exist in like a worksheet kind of format. There's lots of different ones that are available. Mark, we made one, I think, right, for this series.
Yes, we did,
Okay,
and it's going through the approval process now. So hopefully we'll have it by the end of
okay.
the 4 webinars.
Okay. So soon to come, but we did make our a version of one that you guys are welcome to use with your patients when it gets approved. But in essence, these worksheets are structured similarly in that there's usually a list of values, and then people will rank them in some order of things that are most important to them to least important. Sometimes they have them set up where you'll choose the values that are important to you, and then like from that list, you'll create like your top three. There's a couple different approaches, but more or less they function the same way. There are also some value card sorts that exist. There is one that is publicly available from the Motivational Interviewing Network of Trainers. I usually will just Google values assessment, and then their acronym is MINT, MINT. And it usually pulls up. But that card sort has people take values that are on cards and then they'll put them in different piles. So things that are most important to them, things that are least important to them, and then somewhere in between. I really like that one just because it has the definitions on all of the cards. And I found that helpful for working with adolescents, that they have that available. But I think that from my experience, that using these assessment tools can be really powerful for helping our patients kind of work through this. And I've seen it, a lot of my adolescents gain some pretty significant insight from doing this process. But not everyone is going to have time and space for that in session. And so that's where we can definitely utilize reflections and open-ended questions to kind of get there, right? And pull that into the conversation, even if we don't have the time and space for some of the more like formalized assessment tools. So we are going to take a chance to do a little bit of practice here as a group. So I have a couple of examples that we're going to go through. And these are things that patients may say to us in our visits. And then we're going to practice identifying what values we can reflect back to them and what we might be hearing them say. So if you want to throw it in the chat or unmute, you're welcome to. If you had a patient say to you, I can't keep living like this, the lying, it's eating me up inside, what values might you reflect back to this patient that you might be hearing them say?
It sounds like honesty is very important to you, and I can understand why this is bothering you. Or
Yeah. So you paired that with like right, validating that experience while also like pulling out that value of honesty.
What prompts you to need to lie? What situations?
Oh, okay. So that's a good open-ended question. Yeah. Mark, is there anything in the chat?
No, the only thing I have is a question about the
Oh.
values assessment, which I will answer that too.
Oh, there's a question about the values assessment. Absolutely.
Yeah, and I was just going to answer that the same thing that I said earlier, that we're working on one, and once it's approved, I'll send it out.
Okay, perfect. Any other values we can hear from this statement? So we have honesty. Dr. Bowling, Dr. Chavez, do you guys hear anything?
Well, it's not a value, but they sound like they're in a pretty low point. So you have to tease out, is this causing other depression that's kind of bringing them down and making them do other bad choices? And also just, it sounds like they at least are introducing the idea of change and
Yeah. Mm-hmm.
warming up to it. So you can bring that out to them. It sounds like you really do want to change and you're serious about it.
Mm-hmm. Yeah. Yeah. So, Carrie, what I heard you say was a lot of really good reflections, right? Reflecting that feeling back to them. Right. It sounds like you are feeling like really low right now and really down about yourself. Right. And reflecting, like using those reflections to really kind of pull out, some of that change talk and then kind of leading into that. Um, Yeah, any other, which is when we're talking about M, I guess that brings up a good point. That we can use reflections, and Dr. Chavez will talk a lot about this next week, so I don't want to like talk too much about it, but usually, like, there's a lot of different directions we can go, right? So we can, in a statement like this, right, we can talk about, we can do reflections of feelings, we can do reflection of meaning, like what does this might mean to this person, and we can also like reflect that back values. When we're talking to our patients, right, we're often pulled in a lot of different directions, or like there's a lot of really good things that we could ask next, or reflect back to kind of take the conversation. Um, so there, and I'm sure Dr. Chavez will talk more about this next week when we do dive into the reflections more deeply. Um, but yes, there are, in a statement like this, right, there's lots of different directions we could go. I think some other values that that could potentially be here for this patient would be truthfulness, right? Depending on like the relationship that they're lying, like authenticity may be something that they may value for themselves, right? Depending on what they mean by lying. Obviously, there's not a lot of context here. So those are some other potential values that may exist for this patient that we could reflect back. Um, so I chose this example because this is an example of a little bit more of sustained talk, but I think we can still do the same thing of reflecting back our values that we're hearing. So if we have a patient say to us, if I stop stealing, how am I going to be able to keep doing my art projects? Any values that we may hear or take a guess on. We may not be, we can, when we use reflections, right, sometimes we can take a guess as to what we might be hearing the patient say, and allow them to correct us if we get it wrong.
While we're working on that, Mary, do you know that your slides are down?
No, they're
I'm,
down.
I don't, is, Dr. Bowling, are you seeing the slides? I'm not seeing your slides.
Oh,
I I can see the slides.
Oh,
oh,
I
okay.
could, maybe it's just me.
I'm seeing
Yeah.
them also.
Yeah.
Okay,
Okay.
could just be
Anyone
me.
else?
Sorry.
Okay, I was like, I haven't changed anything, so I don't know what happened, but let me know if that does change on your end, for anybody, and we can maybe reshare.
I found it. We're good. My
Okay.
apologies.
No, you're okay. All right. Any values that we might be hearing?
We have
Doing
somebody that
art.
says doing artwork sounds like a value.
Yeah, yeah. So they might value like the like being artistic, right? That might be a value, or self-expression or creativity.
It might be their form of self-expression, and it's
Yeah, absolutely. Yeah, like this might be the way that they, right, express themselves or express their feelings.
We have that there's clearly values in integrity, honesty, acceptability
Mm.
to community. And then there's some cognitive dissonance between values and honesty and creativity.
Yes. Yeah. Yeah, and I think in this example, I think you guys did a good job of identifying, right, where that cognitive dissonance is of like my behavior, or I might have two values that are actually in conflict here, right? And my behavior is maybe reflective of one over the other. Yeah, absolutely. Which I think is a reflection of how like complicated values are. Right, like that we may have values that are in conflict, and right, like helping our patients work through that ambivalence of like how do I make sense of that, and how do I make choices that are going to get me to where I want to go, but also like help me feel good about it. Good. Okay.
another
um
unstated thing, which, like you said before, you can go in a lot of directions with this.
mhm,
But I mean, are they having any money insecurities that would be
mm,
even deeper, like food insecurity and various other things that kind of they're justifying stealing one thing, and then it just
mhm,
spills over into, well, I have to steal, so it
mhm,
makes it kind of okay to do it, or you rationalize it.
yeah, yeah, a good it could be a good description of rationalization. And Carrie, you bring up a good point. I've done a similar presentation where I use this example before, and someone had mentioned, right, like, right, maybe the two values that are in conflict are, right, like if I have enough money to like have buy food for my family, but I don't have enough money to do my art project, right? Like I want to do both. I have a personal need to do both, right? But I'm going to make sure that my family is fed, and then also like I want to make sure that I'm doing my art so I can do both. So yeah, that is a good point, right? That there are probably lots of other things that we'll need to unpack with this patient for sure. Um, any final thoughts we want to add? Okay. So our last example is I don't want my mom to know that I am a failure. What are we here and here?
Your mom's opinion of you really matters a lot, and you are
Mm-hmm.
feeling some like strong feelings about how she is judging or how she judges you or what you're
Yeah.
doing to, you know.
Yeah, yeah. So the value there is like you really value that relationship with your mom, and her opinion of you, right? And kind of reflecting that back and then pairing that with the like, okay, now I can definitely validate and understand how you might be feeling and pairing that with a reflection of feeling. Yeah, I like it.
You can also look at it as a reflection of how you deem responsibility.
Ooh, okay. Mm-hmm. Say
Um,
more about that. I love that. Yeah, so like how like feeling like there is a responsibility that this person maybe is not meeting, and how much they value that. Yeah, that is a super good point.
I was going to add, it seems like your mom has high expectations, not only for you, but you also have high expectations for yourself.
Mm-hmm. Yeah. Yeah, so value maybe like achievement, right? Like valuing reaching that goal that you're setting for yourself. Right. And when you feel like you can't reach that, right? Like that right is probably pretty painful. Yeah, those are great ideas. Okay. Anything else anyone would add? Okay. So, how does assessing values help us to resolve ambivalence? So, um, our goal with MI, like we talked about, is to help patients resolve that ambivalence. And pulling out values and bringing those into the conversation helps our patients to form and strengthen the why behind their change. So, for a lot of patients, right, like we talked about, right, like they may not, before we talk about these things, have a lot of insight into why their values, or they may not have a lot of insight into their values, and why that feeling of cognitive dissonance is coming up for them. And so this is going to help them to strengthen that why. It then helps us to move into the conversation of talking about behavior. So it pairs really well with talking about behavior from two different sides. So these are two approaches that I have taken before when we linking values and behaviors. But Dr. Chavez and Dr. Bowling, you guys can share any more that you guys have used. So we can talk to our patients about how their current behaviors are potentially interfering with their values. And so we'll usually start with a reflection. So we can say, so it's really important to you that that you can be there for your friend and are reliable. So reflecting that value of reliability back to them. How is your drinking getting in the way of this? And so we're posing that open-ended question to help them kind of make that connection between their behavior and their values, and bringing that into conversation. We can also look at it from what behaviors would help this person better match their values. So similarly, we'll set it up by reflecting back kind of what we're hearing them say. So you said that self-respect and self-expression are really important to you and trying to fit in with this group of friends is getting in the way of that. So we're reflecting back that cognitive dissonance that we're seeing. Then we compare that with our open-ended question of what would need to change for you to feel like you could maintain your self-respect in this situation. And so this helps us to move into the conversation about behavior change without invoking the righting reflex. So in MI, the righting reflex is when the patient is perceiving that we are maybe fighting for change, right? Their reflex, right, is to then defend sustaining behavior. And so this helps us to move into talking about behavior without necessarily triggering that righting reflex because we're opening up the conversation to kind of broadly talk about behaviors. And then we're also inviting the patient to explore what that congruence would look like for them. So rather than us saying, this is the behavior that would resolve this cognitive dissonance, we're inviting them to participate and to identify and brainstorm and explore what behaviors would be help them live out their values and help them to kind of process how their current behaviors may be interfering with their values. And so this can pull in and lead to a lot of really good discussion from our patients and help them to think about their behavior in maybe a different way than they were thinking about it before, rather solely comparatively, right? We could approach it solely from a point of view of change. But this does help to strengthen their why and then helps us to ease into that conversation about behaviors. So from here, after we've kind of linked our behavior, we've linked with our value, we maybe have established what congruence would look like for this person. This is where we can move into planning in the planning stage.
Mary,
Yeah.
do you have like, I always felt like with these kinds of questions, it's always the danger is always that you're going to come across saying, well, you're doing this, but your value says this. So you don't
Mm-hmm.
sound confrontational with them. Do you have any tips on how not to sound confrontational? I always tried reframing it, but
Yeah.
I didn't know if you had any other, like the way you have it here, it's like it's not confrontational. It's just
Mm-hmm.
like, oh, you're telling me this. How can we get this where you want it? But I didn't know if you had any other tips.
I think one of the things that would, I guess it is a tip, but it's not like a specific phrase, is like just helping the patient, phrasing it in a way that's allowing the patient to establish what behavior, like to brainstorm the behavior themselves rather than like us saying the behavior. And
Uh-huh.
there have been times when I would say something along the lines of like, you know what, like, it's probably going to get into our last presentation, right? The offer, ask, offer, or ask off, or ask. I always say that backwards. But like being able to like ask for permission to like share your perspective and then kind of maybe highlight that reflection a little bit of like this is right, I'm seeing or I'm hearing you say that this is your value. You really value health. You really value, right, being able to be the type of person who is able to do whatever their goal is. And like you're also telling me that we feel pretty stuck in this behavior. I'm wondering if those things are getting in the way of each other, right? And kind of like framing it as a question rather than kind of saying these things are in conflict as like an absolute. Bringing it just kind of like reflecting that back, but more as a like, this is my perspective. I wonder if you think the same, or I wonder if these things are related. So kind of more a question and a reflection together.
Mary, would it be okay if I share how I kind of?
Absolutely. Yeah, please.
Oh, thank you. So I often use the on the one hand, on the other hand kind of phrase.
Mm-hmm.
So I might say, and I usually use my hands. On the one hand, I hear that it's really important for you to be a really good, reliable friend. And on the other hand, I hear that drinking kind of makes that really hard for you. And sometimes
Mm-hmm.
I just leave it like that, right? But
Yeah.
other times I might say something like, "What do you think about that?"
Mm-hmm.
Or you could also say, like, on the one hand, I hear that your drinking is making it really hard for you to be the kind of friend you want to be. And that makes it challenging to kind of do something different, right? So, and then you could go from there and say, like, if you were going to do something different, what do you think you could do so that you could be the kind of friend you wanted to be, right? Which gets into that behavior piece.
Mhm. Yeah, thank you, Dr. Chavez. That was a great example. I also do use my hands when I do things like that too, so I can relate. Yes. Dr. Bowling, did that answer your question?
It did. Thank
Okay.
you.
Okay.
Chris,
You,
can I make a comment though?
Yeah.
I think pediatricians are becoming like so soft. We don't want to push anybody. We don't want to confront. We don't want to. We're getting like parents where, the lawnmower parent, where we don't want to put anything out, and not saying something is right or wrong, but you can say, you're telling me this is what you really want to be like, and you're telling me that this is getting in the way of that. Let's see what things we can come up with that will fix it. But sometimes that, like, that somebody else puts two and two together the same way you've been putting it together and finally brought you to get help, is something that, actually they get a catharsis, like somebody understands that this is really bothering me and getting in the way of my life. So I think sometimes, we shouldn't, I mean, I don't say, hit them in the head with it, but your example of being, quote, confrontational, I think is just being like, here's how, this is what you're telling me, I'm putting two and two together, this is my addition to get four. Am I right? And let's go from there, since you're telling me this.
yeah, and
Mhm.
I'm not saying necessarily avoid difficult conversations. I you want them to get to those difficult conversations, Carrie, without them turning you off. So you have a goal here. You want them to get better with this. So you definitely are directive, or not directive, but you're guiding them to a better behavior. So you're not avoiding confrontation. You're just trying to get there in such a way that they're not going to turn you off. So yeah, no, I
Mhm.
would agree with you on that.
And I'm
Mhm.
going to be real honest about the way that I do it. And again, this is just the way that I do it. I try to be sort of gentle with it, but in a way that, like, I'm hoping people hear it. And usually I think they do. So I might preface by saying, would it be okay if I share something with you that I think I'm noticing? People usually say yes. And then I say, please feel free to tell me if I got that wrong, because I get things wrong all the time. So I give them like an out, right? And then I put the reflection out there, or I sort of do what I just did when we talk about ambivalence. And then if they're not saying anything, I might say, what do you think? How'd I do? Right? With opening to say, like, you totally got that wrong, lady, or like, you're right on. That is exactly how I feel. And when I teach students, I usually tell students, like, sometimes students are really afraid to put out any type of reflection or to voice any sort of ambivalence that they've heard. And I usually tell students it is totally okay to take a guess and get it wrong. Because I get really excited if people feel like they can tell me that I got it wrong, because that means that they trust me enough to tell me that I got it wrong. And then that gives me a beautiful opening to say, I'm so sorry I got that wrong. Please help me understand, right? So that's the way that I do it, in a way that I hope people can hear.
Mhm.
Those are great suggestions. And actually, quote, by getting it wrong, you learn a lot of the nuance of what, you
Right.
know, hone in on the dissonance quite a bit better, because you hear what you hear, but then they can fine tune something to get so that you get it right. That's an excellent suggestion.
Mhm.
Hey,
Yeah,
Mary, I know you need to move on to the next part of it. I
that's
was just
fine.
going to say, like, the values assessment sheets, for those of us who use those, yeah, your comment was really true. It's like, so you have to have a little bit of time to do it. I've heard people say, like, I've always liked it, using the values assessment tool. I don't use it all the time, but when I use it like when I'm stuck. Like I can't figure out where things are going. It's a great way to get unstuck with a patient. The other place that I think it's useful, some people said to me, like, oh, I like to do it at the very beginning, like on that first visit, they fill it out before they even see me. So then I know where I'm
Mhm.
working from. But just as an aside.
Mhm. No, no, I think that's great. I've never even thought of using it like almost as like a starting place, but I think that's a fantastic idea. Um, to like, because then that will just like, right, lead into all sorts of different conversations. But then, right, we like kind of know where we're starting and you get to know that person, right? It helps to build that relational foundation. And I think one thing that I heard, you saying, Carrie, and Dr. Bowling and Dr. Chavez, you reiterated this as well, but really kind of like reflect what you guys were talking about was really reflecting back that spirit of like empathy and compassion, right? So like right, maybe are sharing things that are difficult for this person to hear. Maybe not. Maybe it's very validating for them that like someone finally understands and maybe is putting words to my discomfort that and like my internal distress that like I wasn't able to say before. But it's really all like it's definitely like if as long as we are coming from that stance of compassion and empathy and non-judgmentalness, that is where right that helps to build that relational foundation and how these conversations and how these questions can be helpful is because we are using that MI spirit. But no, I think that was all great additions, and I appreciate everyone sharing. So I lost my mouse here. Hold on. There we go. Okay. But before we move on to planning, there is one more thing or one more tool I wanted to talk about. When we talk about values and we're starting to talk about behaviors, right, we can move people through the contemplative stage of change. And obviously, I know that it's not that easy, right? That like in one session, in one conversation, right, we move through contemplation, but right, that usually sets us up really nicely for planning. But before we actually get to planning, we want to really explore with the patient their readiness and confidence to change. And so this is where the tools of rulers and scaling questions come in. So our rulers and scaling questions, they're both the words to describe kind of the same tool that we have available for us. And these help us to determine and assess for importance, readiness, and confidence. And we'll dive into all three of those in a slide or two slides. But before we dive into that, I wanted to talk a little bit about how we set up scaling questions. So whether we're assessing for importance, confidence, or readiness, we set up scaling questions the same way. So the first part is to ask our question in the context of a scale. And then we want to make sure that we are defining what each end of the scale is, which I know seems pretty for a lot of us. It's like, oh yeah, obviously. But I have seen clinicians and students forget that part. And then what that does is it ends up like the patient is confused on what 1 and 10 means. And so it is good for us to remember to define them. So on a scale of 1 to 10, for our example, with 1 being the least and 10 being the most, how ready are you to start applying for jobs? Now, the number, like the scale itself, is largely up to what you want to use. If you want to use 1 to 10, that's fine. If you want to use 1 to 5, that's fine. I had some patients when a couple years ago, I was working with a couple patients that were Taylor Swift fans, and so anytime I needed to use a scaling question, we would do 1 to 13, since my understanding is that is Taylor's favorite number. And so, right, again, that relational foundation. Um, right, really meeting my patients where they're at, but whatever number you want to use is perfectly fine, as long as we define what each end is. And so after we ask our question, typically most people will respond with a number, so they'll tell us what number they're at, and then we're going to pair that with part two of our scaling question, which is to ask why they chose a number smaller than the number that they chose. So tell me why you chose a 6 and not a 4. And so this is going to evoke change talk because they're going to, we're asking them to kind of defend or draw out why they are more ready to start applying for jobs than they could be out of 4. If we reverse those numbers, we're actually going to be evoking sustained talk. So if we say, tell me why you are a 4 and not a 6, then they're going to tell us why they're less ready for applying for jobs. And that's going to support that conversation of sustained talk rather than supporting that conversation of change talk. So whenever we do scaling questions, no matter what we are using what type of scaling question we use, they're always kind of set up this way. So let's talk about our three types of scaling or rulers that we can use. So we can talk about, or we can ask questions about importance. And so on a scale of 1 to 10, how important is it for you to quit smoking? And so what this does is it does help to draw out that internal motivation for change. So I've worked with a fair number of people who were either on drug court or on probation for substance use. And very commonly, when I was working with those individuals, they had a goal of quitting whatever substance they were in legal trouble for. And so that was their goal. But when I would ask them questions like this, right, what I would hear back from them is it wasn't like on a scale of 1 to 10, how important was it for them to quit smoking weed, right? They may say, like, for them as an individual, it might be a 2, but if I would ask them, right, how important is it for you to get off of drug court, right, that would be a 10. And so this helps us to really see how much internal motivation we have in front of us and how much external motivation we have. And so that was where I would use these assess for importance. That would really help me get that information of how much internal motivation I was or my patient had for change. Dr. Chavez or Dr. Bowling, do you guys have any other situations where you would want to assess for importance?
I kind of do it always. I like doing importance before I do confidence, where it's like, is this even
Mhm.
an important behavior? And one thing that I do a little differently too is I even go 0 to 10. I like 0 to 10 because I like them to be able to say, I have no interest in this at all. So,
Mhm.
I do a similar thing as Dr. Bowling. I usually go 0 to 10. But I think whatever scale you pick is totally fine. You just have to
yep.
define the ends, right?
Mhm.
Um, but I do it when we're talking about, because I work in medical clinics. So when medical providers are talking about changes to just moving your body more, changes to the way that you eat or drink, I usually assess importance for both the caregiver in the room and the adolescent, or I always say do it if it's developmentally appropriate for a child. So I wouldn't do it with an 8-year-old, right? But I would probably do it with like a 12-year-old or a 10-year-old. Um, because I want to see if both individuals are in the same place in terms of importance. And then if there's a discrepancy, we can also talk about that too.
Mhm. Yeah. Yeah, no, those were great examples, and great times to use. And honestly, there's not a bad time probably to use to ask about importance, but yes, all of those are absolutely fantastic. The second scaling type question that we can ask is readiness. So how ready are we to make this change? So on a scale of 1 to 10, how ready are you to stop self-harming? Um, and so this is a good question to pull out to kind of help assess if this patient is ready to kind of move from pre-contemplation into planning, is kind of how I would use this question to really like, are we ready to make this change? And these do kind of build off of each other, not that you have to do them in this order by any means, but I think like sometimes we see patients who like this is really important for me to change, but I'm not quite ready for it. And that's going to tell us that right, we're going to need to continue right resolving some of that ambivalence to help this patient feel like they're ready for this change. We can also use this to kind of maybe like for this example, right? Maybe they're not willing to stop self-harming, but maybe they are willing and ready to like go to therapy, right? And get a therapy referral. Maybe they are ready to maybe there's like a coping skill that they could use and they are ready to use that even though they're not really ready to like take self-harming off the table. And so like that can also be a tool that we can use to maybe it's not the specific behavior or the target behavior that we're aiming for, but is there like another step that kind of helps us get there that we are ready for? So again, just all things that will help us formulate our plan when we get to that stage. Dr. Bowling or Dr. Chavez, any thing you would add for readiness?
If we can go back to importance, we had a question in the
Oh, yeah,
chat.
for sure.
It said, is it ever of value for a provider to share their level of importance in a way that is reflective and supportive?
So kind of like doing some self-disclosure on like how much is important to me. I just wanted to make sure I understand the question correctly.
Yeah, this
Okay.
is Melanie Youngblood. I what I'm thinking of is, and full disclosure, I am in recovery from alcoholism for 2 or 3 decades now, and I don't disclose that to families. But when I talk to them about issues of addiction or substance use or self-harming, I will say, to me, on a scale of 1 to 10, it's really important to me that we get you to a place where you feel like you don't need that anymore.
Hmm.
How, but it's important to me also that we go there in baby steps. Is there a baby step that you can think of that will help you feel calmer or more centered?
Hmm.
Sometimes I think that bridges what the other doctor was saying about being a little more directive, because I feel like my opinion should be part of the discussion or my recommendation, but it's the best way I've found given my past, because that has been done with me in the past, to bring that forward to my patients, if that makes sense.
Hmm. Hmm. Yeah, and I think when we talk about self-disclosure, I think that like it obviously is case by case. We want to make sure that we are doing it appropriately and using it at appropriate times, just like as a general rule for self-disclosure. But I think what I hear you saying, Melanie, is that the like what you're doing is you're telling them that like this is important to me, that you get to the place that you want to go. Like, and you're kind of saying like it's your way of partnering with them and collaborating with them of saying these are the things that like it is important to me that we get you to the place you want to go, and like me as your provider, right, like I like want you to be in a place that you are right, are meeting your health goals as well. And so I think yeah, so kind of like I guess what I hear you saying, less of like you sharing your, it obviously you're sharing your importance, but you're also right, sharing that you are willing to collaborate with them. You're willing to join them in this process and helping them figure it out. Dr. Bowling or Dr. Chavez, do you guys have any thoughts that you guys want to add, or maybe a different perspective?
I don't have a different perspective, but I love what you just said, Melanie, what I'm also thinking is, what would it be like to say to your patients, and please know you may already do this, right? Um, but I really care about you. I see you, and I know that this is important to you, or something like that, right? Because I feel like that is what you're really saying. Um, and that too feels very much like partnering with them to me.
Mhm.
What I usually say is, I'm glad. I don't start with that. I usually say that after they've shared what's important to them, and I say, I'm glad that's important to you because it's also important to me. You are important to me. What you value and what you want to do is important to me to practice safely in this room, is usually the way I put it.
Mhm.
I think that's beautiful.
Mhm. Yeah, I think that is great. And definitely in the spirit of it mine. Um, all right. We have one more scaling question or tool that we have available to us, and this is assessing confidence. So this is where we're going to assess how confident is this person in making this change. So on a scale of 1 to 10, how confident are you in your ability to cut back on drinking? I think that this is really important to help us to assess this person's self-efficacy. I think I mean, this is true for everybody, I think, but right, we're not super likely to do things that we don't think are going to lead to a positive result. Right? Like, if I'm not confident that, like, I'm going to, um, be able to fix my car right, I'm not going to try to do that. Right? Because I don't want to fail, or it feels like it's too big of a task for me to overcome. And so I think like That is very common for our patients, right? And so I think that assessing confidence is really, really important to help identify, and especially when we're talking about planning or we're nearing that planning stage, right? Like, how confident are we that we're going to be able to do the things that we're talking about? Because I think for a lot of our patients, right, they may have already tried change and felt like they failed before. And so, right, that really, like, we want to honor that. That history that like they may have tried a couple of different things and feel like they haven't gotten to the change that they wanted, which is going to affect their confidence. And so helping us understanding that and really bringing that into the conversation, I think is important. Dr. Chavez and Dr. Bowling, anything you would add? I know we're nearing the end of our time here, so I don't want to miss out on. I don't think I actually only have a slide or two left, so I think we're doing okay.
You're going to go over how to respond to the number they give you. Yeah, which is the important part too, I think.
Mm-hmm.
Yeah.
Yes. So I wanted to highlight two differences here. So where um, ideally, in an ideal world, we would have someone who's 10 out of 10, right? It's 10 out of 10 important to them, 10 out of 10 that they're ready for change, and 10 out of 10 confidence. But we rarely ever see that, right? Like that would be, right, an ideal situation. Oftentimes, right, we see various numbers that will fluctuate. And so I think I think what Dr. Bullen, you were saying, like understanding what this number means to them, I think is really important. So tell me why you picked this number. Tell me what this number means to you. What does this say about you, about where you're at, given, right, what number you share? I think two common situations that we have happen though is we have someone who's reporting high confidence and low readiness. So for example, someone may say like, yeah, I could stop if I really wanted to, right? Like anytime I want to stop, I can, right? Things of that nature, right, would be where we might hear them saying, or maybe they give you a number, right? Maybe they're an 8 in confidence and a 2 in readiness. So what that tells me is that we're usually probably like on the spectrum of contemplative stage of change, right, closer to pre-contemplative stage. And there's still more work that we need to do to resolve ambivalence. And so we want to keep working through our MI tools to work with that patient to resolve ambivalence. We may also see kind of the opposite. We may see someone has high readiness, whether they are, whatever the number they report to us, like high readiness and low confidence. And so, for example, right, someone may say something like, I am definitely ready to start changing my diet to lose weight, but I'm really not confident in my ability to say no to my friends when they want to go out for lunch every day. And so what that's telling us is that, right, on the scale or spectrum of contemplative stage of change, right, we might be closer to that planning. And we want to use that information and pull that into our planning with our patients to help build their efficacy and explore the barriers that are getting in the way of that confidence. And so this might look like, depending on what role we're in, right? Like we'll obviously want to keep to our scope of our role, right? But that might look like making referrals to other services, right? So like if you are a provider working with this patient, right, you may refer them to therapy or if you are in a therapeutic role, right, working with them on building setting boundary skills, assertiveness skills, things like that. You may be interested in sending them for a referral for a dietitian or a nutritionist who can help them, right? If we're going to go to McDonald's, what are some things that we can order that are going to help us stay within our nutritional needs? What are some things that you could buy at the grocery store to pack for lunch, right? To give you another option for lunch. Right. So this is going to help influence our planning as we get to this stage. So that way, right, we can help to increase that confidence and address some of those barriers that are getting in the way of their readiness. Okay, I know we only have 2 minutes left. I think we honestly talked about all of this already. But I wanted to kind of take a second at the end here just to kind of link all of this back to the spirit of MI. If we remember from last week, right, the spirit of MI is going to be what is like overarching all of our approaches, right? These are things, it's kind of our stance to be in the room. And so we want to make sure that throughout this process, as we're talking about values, as we're talking about behavior change, their readiness for change and things like that, we're collaborating with our patients and families. We're allowing them the autonomy to tell us what their values are and tell us what behaviors they think are going to create that alignment for them. And then, like we talked about already, but just to reiterate, right, coming in with that non-judgmental stance from empathy and compassion, and that um, as our way of being with our patients in the room. Um, so real quick, Dr. Bowling or Dr. Chavez, anything that you guys would add in our last minute?
I would. The one thing with the readiness ruler that I really like doing, you can always ask them, you picked a 7. If you could say, why did you not pick an 8 or a 9? They're going to give you like, well, I got this problem and that problem, and it helps you identify some barriers. But the thing that I think is really valuable with those readiness rulers is saying you picked a 7, why not a 5? Because then what you'll find is they will argue for why, well, I do think it's important for me to get healthier. I do think I have the confidence to do this. I've thought about trying it this way, which might elevate my confidence. So it's useful, or I think, to always go under as well as go over when they give you a number.
Yeah, and I think oh, go ahead, Dr. Chavez. Yeah.
Perfect. Thank you. Just to add to what Dr. Bowling said, just real quick, I love that too. And the other thing that I also do is I will say, let's pretend somebody picked a 6. I will also say, what would a 6.5 or a 7 look like? Which gets at that behavior piece, right? And so that helps somebody to really think about, okay, well, if I were going to be a 6.5, I would need to be doing X, Y, and Z, right? Kind of help them think forward. But I do that thing where I go backwards too and say, why not a 5, right?
Yeah, and I think what I realize, well, yeah, anyway, to add on to that, something else that I do, I mean, I love using those like 0.5 markers, or even like I'll do like, what would a 0.1, right? Like a 6.1 be, right? And really like validating for them that like we can make these small changes, right? We don't have to be, we don't have to go from a 6 to a 10, right? Like that's not my expectation for you. Another question that I forgot, or another question I like to ask patients at this stage would be like, what, like, okay, you're at a 6, like, what do you think it would take to get to a 7, right? Kind of like same line of thinking as your question, Dr. Chavez. So yeah, there's lots of things you can do with these numbers as they're coming at you, and lots of ways that you can explore them. And the number might change week to week, so it might be important for us to ask almost every week of like, okay, like how important is it to us this week? How ready are we this week? Because lots of things can change as in the time between that we see our patients.
I think you bring up a good point that readiness can vary from minute to minute, day to day, week to week. And, it involves sometimes willpower, like your example with eating, with your friends and things. So, all those things change. So, you could just say, what makes you feel like you're at a 6 today? And that way it kind of clarifies that there is true variation in your how you feel today, this minute.
Yeah, that's a super good point. It helps to like put it into context, right? That like we're not expecting you to be like, if you are saying you're ready and confident in my office, and then you leave my office and that number changes, like that's okay, right? We can expect that. Absolutely. Any other questions or anything in the chat that came up, Mark, that we missed?
I think you kind of addressed everything that was in the chat.
Okay.
Do you mind to just go
Oh,
I think it's
yes.
one more slide ahead? Yeah. So I'll just leave that up there. If you want to real quick claim your CME or MOC Part 2, that QR code will take you to that. Otherwise, I will send a follow-up email with some of the links we talked about today, and then also the link for this form. We had somebody mention that it was kind of acting strange, and I looked into the issue for the form on the back end, and I think I've got it all fixed to be able to apply for your CME correctly. If not, please feel free to reach out to me and I will take a look at the form again or help you fill that out correctly. But otherwise, we want to thank Mary for speaking with us today, and Dr. Bowling and Dr. Chavez for being on our panel, and of course, ODH for sponsoring this webinar for us today. And wish you all a great weekend, and hopefully we'll see you back for the 3rd session next week. Thank you.